Hi, everyone. Good evening. I'm Dr. Prasad. I head the academics at Yashoda Hospital's high-tech city emergency department. Today, I welcome you all to the Friday webinar series where we bring you very important topics which are pertinent to your emergency clinical practice. Today, we have come with a very interesting topic and which is very commonly done in the emergency is putting a patient on non-invasive ventilation. So to speak about this topic, we have Dr. Sriram, who is an emergency physician at High-Tech City Yashoda Hospitals. So over to you, Dr. Sriram.
Good evening, one and all. Today we are going to discuss about our topic, non-invasive ventilation, and how to identify NIV failure. Okay. We go through the usage of non-invasive ventilation almost every day in our emergency department. Okay. Coming to the basics of the blood gas, here are the basics. We come across the pH primarily, which is the normal range between 7.35 to 7.45. And coming to the PCO2, which is normal range between 35 to 45 Hg, which corresponds to 4.7 to 6 kilopascals, and also PO2, which is 10 to 13 kilopascals. Yeah, and we consider the hypoxia as less than 8 kilopascals, hypercarbia to be greater than 6 kilopascals, and acidosis, we know that when the pH is below 7.35, and alkalosis when the pH is above 7.5. When do we put a patient on NIV? The indications, coming to the indications, when to use an adult non-invasive ventilation. This is an algorithm. Potentially reversible acute hypercapnic respiratory failure, which includes increased work of breathing. Okay. And there are other specific disease indications in which we use the NIV. Some of them are here. When we can use the NIV in COPD patients in which the pH is less than 7.35 and the PCO2 greater than 6.5 kilopascals and respiratory rate greater than 23 despite 1 hour of medical management. The next one is neuromuscular disease, the respiratory illness which includes respiratory rate greater than 20 if usual VC is less than 1 liter or pH less than 3.7.35 and PCO2 greater than 6.5 kilopascals. And also in obesity, which involves the OSA factor and pH with less than 7.35 and PCO2 of greater than 6.5. Along with that, we consider respiratory rate in this two greater than 23 cycles per minute or daytime PCO2 greater than 6 and the patient is drowsy. NIV is not usually indicated in asthma. Okay, and the contraindications, we do not use the NIVR. The absolute contraindications include undrained pneumothorax, facial burns, fixed upper airway obstruction greater than 2 weeks of post-esophagectomy, and the relative pH is less than 7.15, GCS less than 8, confusion or agitation, cognitive impairment, considering NG tube placement in patient with vomitings. These are the relative contraindications when we do not want to use an NIV. And also the indication for ICU referral, acute respiratory failure in asthma with also with an impending respiratory arrest. Yeah. And NIV treatment failure when there is decreased chest wall movement and unable to decrease PCO2. Okay. Inability to maintain target saturations on an NIV. Need for an IV sedation, close monitoring. Possible difficult indications. These are the indications for an NIV in ICU referral. The next one is the complete NIV care bundle and prescription on sender. NIV setup. We need to select appropriate interface with the escalation port and complete machine setup by a component practitioner. which we use the paramedics and respiratory therapists. Select correct mask and port interface. Okay. Selecting an NIV mask is also a prior thing that needs to be done before putting a patient on NIV support. That can be done by placing the cover of the NIV mask next to the face of the patient, which can uh, make you assess the size which can be used for the patient. Okay. The starting pressure must be between the IPAP must be between 10 and 15, and the EPAP at least 4. It must be increased in OSA patients. Next, activate emergency alarms and set the backup rate around 12 to 16. Explaining the treatment to the patient prior to fitting masks is must. Okay, we need to reassure them before putting them on an NIV. Most of the times, it will be a challenging task for our ER physicians. Next, we need to increase the IPAP over 10 to 30 minutes to at least 20 to 30 centimeters. Okay. Rise time, I by E ratio that must be monitored continuously. That must be on a higher side, at least 1 is to 2 to 1 is to 3 in COPD. And in NMD or OHS, it must be 1 is to 1. This can be said by a competent practitioner. Next, we need to repeat an ABG after an hour and at 4 hours from initiation. That decides about whether we need to consider the need for an arterial line or not. Next one is monitoring while on NIV. Continuous cardiac and saturation monitoring for at least first 12 hours is must. Ensure the PCO2 and PO2 saturation parameters are set. Alter the NIV settings as per the patient condition. We need to alter it according to the physiology. Use NIV for as much as time as possible for in the first 24 hours. You can allow breaks whenever the patient is feeling discomfort, or you can wean over later on for the next 48 to 72 hours, depending on the clinical discretion and the ABGs. Okay. If the pH is less than 7.25 on an optimal NIV and the respiratory rate is greater than 25 continuously, or the patient may get deteriorated by means any new onset confusion post clinical review, check the synchronization. You need to check the mask fit, exhalation port. You need to consider chest physiotherapy, bronchodilators, and so and so. If the patient is struggling to tolerate NIV or continues to deteriorate, it's not for escalation. We need to refer to palliative care. The next one we can see at the blood gas, in which there is a complete NIV failure. Okay, the primary ABG was on arrival. Even after 2 hours of NIV, the patient failed to ventilate. The resultant ABG is on the right side. Next part, we need to see when to use a vented NIV mask and when to use a non-vented NIV mask. Okay. Vented NIV mask. These are used in home BiPAP or CPAP machines. These include a single limb circuit without expiratory valve. When no external CO2 removal system exists, because mask itself provides a fixed leak for CO2 clearance. The image below shows you how a vented mask looks. There will be 4 holes at the mouthpiece, okay, that can clearly indicate the vented mask. Okay. When we use non-vented mask, when we are connecting an NIV to an ICU ventilator, which includes a dual limb circuit, and also infection control settings, COVID with filters, because ventilator already has active expiratory valve, we can use this non-vented mask. And it looks like this. It will be having a blue colored knob at the mouthpiece. Okay, there you can see that there is a no vent or nothing is at the mouthpiece. Yeah. Differences between vented and non-vented mask. Okay. when we look at the exhalation system, there are built-in leak ports. The 4 holes we can see in the vented mask, and in non-vented mask there are no ports. And the CO2 clearance through the mask itself, the CO2 gets cleared off. And in non-vented mask, it needs a circuit valve or leak port. In vented mask, we use a single limb circuit. In non-vented mask, we use a dual limb or a single limb plus valve. Typically, we use vented mask in home CPAP and BiPAP, whereas the non-vented mask, we use it in an ICU ventilator. And yeah. We don't need an extra valve in a vented mask, whereas we need in a non-vented mask. In the leak, the intentional continuous leak is present in vented mask, whereas minimal leak can be seen in non-vented one. Control of pressure will be less precise in vented mask as compared to the non-vented. And also the aerosol control, more aerosolization can be achieved with the vented mask, whereas better containment, if filters are possible, can be possible with non-vented mask. Yeah. What happens if the wrong mask is used? Vented mask plus ventilator, these cannot build pressure. There will be massive leak, poor ventilation, and alarm issues. If at all we are connecting the wrong circuit or we are adjusting a different circuit to a different mask, that needs to be reassessed and changed. When a non-vented mask is connected to a BiPAP, right, which is a no leak port, there will be lot of CO2 retention that may cause CO2 narcosis or worsening of the pH. There will be rebreathing in this setup, which causes hypercapnia, and also there will be dangerous ventilation failure. Yeah. What does the agitation in NIV patient mean? Considering the agitation, there will be hypoxia or decreased saturation. There will be worsening clinical condition, early NIV failure, rising PCO2 causes ventilation failure. There will be both mismatch with oxygenation and ventilation. Ventilation mismatch, the wrong, it, it occurs when there is wrong I by E ratio or poor trigger sensitivity. The agitation will cause brain hypoxia until proven otherwise. Yeah. Coming to the HACOR score, it is a bedside tool used to predict the failure of NIV. A higher score greater than 5 suggests greater risk of NIV failure. We need to assess the patient putting on an NIV primarily with the HACOR score, which includes the components, the heart rate, acidosis, consciousness, oxygenation, which can be seen in PF ratio, and also the respiratory rate. Interpretations of this HACOR score, less than 5, there will be a low probability of failure and low risk of NIV failure too. And greater than 5 or equal to 5, there will be a strong prediction towards NIV failure. Why the HACOR score is useful? This is to prevent the deterioration of a patient when we consider to put them on an NIV. Early action can help patients who may need intubation sooner. Objective guide is to assist clinicians in making clear evidence-based decisions. Yeah. And better results and outcomes linked with low hospital mortality through timely intervention. This is how the HACOR score is made. These are the components that I discussed earlier. The heart rate, which must be below 120. Above 120, we consider it as a score 1. And acidosis as follows. The pH levels less than 7.25 will have a score of 4, and greater than 7.35 will be 0. And the in-between scores are 2 and 3. Conscious level 15 on 15 GCS will be considered as a score of 0. Less than 10 will be 10. And anything anywhere between will be anywhere between 13 to 14 will be 2, and 11 and 12 will be 5. Next, the oxygenation, which we calculate as a PF ratio, greater than 200 will be considered as a score of 0. and less than 100 PF can be considered as 6. There itself we can consider this as a HACOR score greater than 5, and the patient might not be an ideal person to get ventilated with NIV mask. And also the respiratory rate, which between the range of 30 and 45, above that less than 30, the score is 0, and greater than 45 has 4. Next one, the red flags of NIV failure. The increasing agitation despite reassurance and falling saturations, rising PCO2 or hypercapnia, that causes worsening acidosis. And also reduced consciousness. Any deterioration in the GCS of the patient, these can be considered as red flags of NIV failure. These don't persist blindly. We need to consider an intubation whenever an NIV failure occurs. Yeah. How do we know agitation and clinical worsening? In agitation, the patient tidal volumes will be generated. In NIV failure, the tidal volumes are usually inadequate, causing desaturation. Tachycardia can be considered in both conditions. When we give an anxiolytic medication, yes, you may give anxiolytic doses, but very close monitoring is required. There is no clear no for this, left to the clinical discretion of the physician who is considered. Yeah. We usually document the settings and the plan of care in patients who have started on an NIV. When a patient is on NIV, the indications and all, along with the settings, the kind of mask we are using, along with the primary ABG findings, we need to consider the HACOR score and need to reassess the score every 15 minutes, at least for the first 1 hour. After an hour, we need to repeat an ABG so that we can find out whether the patient is improving or worsening. That can be seen by the saturation and carbon dioxide levels. We need to also watch for the altered sensorium and drop in GCS along with the continuous BP monitoring too. We need to look for the agitation or pulling manners, or the patient gets uncooperative or sweating profusely. Whenever there is this kind of issue, we need to do an intubation SOS. Along with that, bedside chest X-ray along with lung ultrasound is needed. The quality that is used for an NIV mask is silicone non-toxic medical grade material. However, we need to check for allergic reactions. Some may not be ideal for putting them on a silicone material who are allergic to that material. And also single patient used to be considered. And also the storage of these NIV mask must be between 15 to 60 degrees centigrade. This should be also considered in an ambulance storage. Yeah. One more thing I need to add this. There is also risk of infection with vented and low risk of infection with this vented mask where there will be a wall present. Yeah. Considering that, we need to place or select the vented or non-vented mask accordingly based on the patient condition and also the discretion. Yeah. Thank you.
Yeah. Thank you, Dr. Sriram. I think it is a very clear and crisp talk. So I don't see any questions in the chat box, but I have few questions that we can discuss. Can you put your presentation on? Can you share your
Yeah.
presentation? It's not visible. Your presentation is not visible. So basically, whenever you start an NIV, the first and foremost thing is you'll have to look at the indication for an NIV, and you'll have to calculate the HACOR score. And then you'll have to see what are the vital parameters, of which, if you have already seen the HACOR score that is shown by Dr. Sridham, so the majority of the score is given to the consciousness, right? Yes, Dr. Sridham, yes, right? Yeah. The highest score that is given,
Yeah.
the HAVOC score is 10 for the consciousness. So it obviously tells that a patient who has an altered sensorium cannot be a candidate for an NIV. That's a first and foremost condition. And then you look at the blood gas, and then based on the blood gas, you will decide. The other parameter that you would consider when putting a patient on NIV is work of breathing. You wanted to decrease the work of breathing. These are the primary things that anybody would consider before placing a patient on, before making a decision of placing an NIV. So then, once we have decided that this is an indication for an NIV, then we will have to select the particular mask size. Sriram has already delineated how do you look at it, and as ER physicians, we all know how to measure it. You have to put the mask against the patient's face, and then look at the appropriate size. So then you have to match up with the nose bridge, and somewhere in the lower part of the lower lip and the chin, the bottom should rest on. And then first and foremost is explain the patient that you're going to get a forced air into you, and then ask them to just put the mask against their face without any fixation, and ask them to let them feel how the air is going to come inside, and let them feel how the air would be. And then once they feel comfortable after 4 to 5 breaths, bring it slightly closer to the patient's face, and then just enclose it onto the face without strapping. Then look at the patient tolerance, and then you can fix the mask. So he has beautifully explained the difference between vented and non-vented mask, and then how the vented mask is beneficial, and what are the uh, side effects of vented and non-vented mask. So just these days they have made the manufacturers have made it as a foolproof. These days we cannot connect vented to non-vented, vented to a ventilator, because the fittings won't fit in. In olden days we had a mechanism to fit in, but these days fortunately we don't usually, they're made a foolproof. You cannot, if you even if you wish to connect a vented mask to a ventilator, you cannot do that. And that is one part of it. So once you connect to the patient, your role doesn't end there. That's where your role begins. And then you'll have to monitor your patient for tachycardia, for any agitation, for any drop in saturation, or for that matter, your primary aim is to decrease work of breathing. Is your tachypnea coming, is in a downtrend or not? For example, if you have put a NIV for a patient of 35, is it after an NIV trial, is that respiratory rate remaining the same, or is it dropping down? So if it is dropping down, there are two things. One is dropping in terms of benefit, or is the patient being exhausted despite an IV? If the patient has an exhaustion, also he will have an um, you'll see a bradypnea, or you will see a decreasing trend of respiration. So you must be in a position to differentiate whether the patient is improving or patient is being exhausted despite being on NIV. These are the things that you should monitor. And apart from that, you are giving a positive pressure ventilation. You should also put your eye on the blood pressure. This is how we see. And he has beautifully answered certain questions which he made for himself. I think the one very important thing is, once you put something close mask on to even to our face, we feel claustrophobic. So patient can have an agitation. So how can we know difference between agitated patient or someone who is hypoxic and irritable? So he has told already. Tachycardia is there in both because once you're anxious, obviously your sympathetic system is getting stimulated and the heart rate is going to go up. So, or if it is hypoxic response also, the first response would be tachycardia. So simply by looking at the tachycardia, we cannot completely differentiate whether the patient is agitated with anxiety or because of the hypoxia. So what is that parameter that will decide is if the patient is agitated, he's not going to generate a tidal volume. So if he's going to generate a tidal volume which is sufficient enough to maintain his ventilation. So whereas if the patient is non-compliant or there is an NIV failure or his respiratory rate is going very high, then probably and your tidal volumes are not generating. It means that it is a hypoxic induced reaction rather than simply anxiety. This is one thing. So the other question that he answered well are usually there are different school of thoughts um, on do you have to give a patient an anxiolytic dose. That is completely left to the discretion of the doctor and the at that moment how how you are loaded with your emergency cases. If you are able to monitor very closely, you can still give a anxiolytic dose and watch very close with the patient. So this is one thing that we should watch. And then other indicators that he has explained are I think the quality is also covered in this. So where do you have to store your mask? Because it's already a summer season. So if you're going to pick up a patient in an ambulance, so ambulance temperature should be controlled to put the mask in an ambulance, especially somewhere like India where your temperatures are pretty high in the summer. So that is one thing that is covered. And then if you can see this ABG, Sriram, can you just focus on this ABG?
Yes.
Yeah, if you can see on this ABG, the first ABG shows clearly type 1 respiratory failure, metabolic acidosis, right? But I would say it is a mixed acidosis because his respiratory rate was 35, if I'm not wrong. So if this patient respiratory rate is 35 and his PCO2 is still 41, so definitely he is not washing the he's not washing out CO2 for the tachypnea that he has. So basically 41 for him with this pH and that respiratory rate is definitely high. So obviously the 41, although it looks like a normal range, it is not normal range for his altered physiology. This is the ABG that we have taken. And the second ABG in this patient, if you can see, there is a deterioration in the ABG. The 6.9 and PCO2 has gone up. So what we would have done differently in this patient is we would have taken an ABG after 1 hour so that this early intervention would have prevented him from going into respiratory acidosis. I think with this, I'll close my points. If you have any questions, we will take. No questions? Sriram, anything you want to add?
Yeah, nothing, sir. It's fine.
Okay. Okay. So if there are no questions, and then you can always post your questions in the chat box, and or the video link will be shared to all of you, or you can post there. If possible, we'll try to answer those questions later. All right, we'll close the session. Thank you, Dr. Sriram.